Okay, I think we'll get started now today. I just wanted to give our participants an opportunity to fully sign in, but I got my reminder, so I am sure that we're starting on time. Just a note that the session is being recorded, and so it will be posted in an area that can be accessible after the talk today. My name is Barbara Shea, and I want to welcome you to the College of Rehabilitation Sciences Illuminate Speaker Series. I'm going to tell you a little bit about the Illuminate series and then introduce our guests today. So the Illuminate Speaker Series provides presenters with an opportunity to both inspire and incite collaboration, as well as to engage with like-minded individuals. We want to be able to impact and enhance the health of others, and then through this initiative, hopefully exchange information and ideas that advance and enhance knowledge, give us an opportunity to engage in scholarly dialogue, as well as a venue to highlight and showcase creative and innovative work. So we're pleased to have this venue to be able to do this. I want to let you know that there will be a slide at the end of the presentation, which will have a survey so that you can fill it out as an audience and give us your feedback. The next slide, please. So I want to spend a moment of our time doing a traditional territories acknowledgement. With respect to recognition and Indigenous peoples, I position myself as an ally and ongoing learner of the harms and mistakes, not only of the past, but those that are continuing. The University of Manitoba campuses are located on original lands of Anishinaabeg, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. I would like the next slide, please. So I want to introduce our two speakers today. Our two speakers are Dr. Ed Giesbrecht and Mel Major. I'll start with Ed, is an associate professor in the Department of Occupational Therapy in the College of the Rehabilitation Sciences at the University of Manitoba. He is the co-principal investigator of the Accessible eHealth research project, which has been funded by the University of Manitoba and Amsterdam University of Applied Sciences. And he's also the principal investigator on a CIHR-funded eHealth wheelchair skills training program called Team Wheelchair. Mel Major is a PhD candidate. She's a physical therapist and senior researcher in the fields of primary care rehab after critical illness, primary care rehab after critical illness. She works at the Faculty of Health at Amsterdam University of Applied Sciences in the Netherlands. She's involved in many research projects focused around physiotherapy intervention after critical illness in the primary care setting, and the application of continuous monitoring and eHealth in collaboration with the Department of Rehab Medicine at Amsterdam UMC. She will be defending her PhD thesis on this same subject in April 2022. So we will now hear from Ed and Mel, and we will have dedicated time at the end of the session in order to answer questions, and I'll be facilitating that at the end. So I now have the next slide and leave it to Ed and Mel to do their presentation.
Yes, good evening, everybody, or good afternoon, but good evening from the Netherlands. Sounds like we're in the Eurovision Song Contest. In any case, it's up to me to introduce the project, and then Ed will continue with the methods and the results of the project, and then I will take take on part of the discussion. And then we would really also like to hear from the people that are present. Just to introduce the project, this project came from a collaboration that has been existing for a while already between the University of Manitoba, between the College of Rehabilitation Sciences and the Faculty of Health at the Amsterdam University of Applied Sciences. And both universities had developed a seed funding call. And on that call, we submitted a project related to accessible eHealth. And found that there were actually at both faculties a nice number of researchers and faculty members that were interested in this topic of what is needed to provide accessible eHealth or Telerehabilitation interventions for patients in primary care, and what do clinicians need to apply this Telerehabilitation. Could I have the next slide, please? Just to provide a little bit of context on in which way our countries are similar and also in which way our countries are different. Unfortunately, we didn't get to skate on the river in Winnipeg. And I'm actually not 100% sure if the Canadian team got to do some boating on our Amsterdam canals. Yeah, that is, I guess, a big difference. Our canals don't freeze over that often. I think once every 10 years. Another difference, if you could click for me, Ed, thank you, is that there's actually a lot more physical therapists in the Netherlands compared to Canada. I also looked at, very important, the occupational therapists, and there's about 9,000, a bit more OTs in Canada, of which 42% work in community setting. And in the Netherlands, there's about 4,500 OTs working, of which only 17%. Maybe those stats are a little bit outdated, but about 17% are working in community settings. So that's quite different. And if we look at the physical therapists, in the Netherlands, about 80% are working in primary care settings and 58% in community settings. If you could click for me again, Ed. Another nice difference is that that our small country only, it's obviously much smaller than your faster country. And if you click one more time, then you can also see that there's a big difference in inhabitants. So just looking at this, you could say there's probably a lot more need for telerehabilitation, and maybe also a lot more experience in telerehabilitation in the Canadian context, as obviously these distances are a lot bigger. But we are about to find out if that is indeed true. Could you click once more, Ed? So what we started this project with was that we wanted to look at, okay, the worldwide pandemic obviously forced us to, as clinicians, so physical therapists, occupational therapists, respiratory therapists, and dietitians, it's forced us to be creative in the way we could provide interventions while keeping our distance. And that could be by some physical therapists or some therapists, some clinicians were quite creative in providing video consultations, or even starting YouTube videos or making podcasts or whatever. But there were also, I would say there were two types of clinicians. There were also the clinicians that were trying to try really hard to just stick to what they were used to doing. So they would maybe initially provide still face-to-face care, but with full personal protective equipment, dependent on if the patients allowed that. But in any case, what happened was that there was a shift to remote practice, and that not necessarily led to smiling clients. this is something that we wanted to find out. So a couple of questions came from this situation that we tried to address in this project. Could I have the next slide? So one was related to accessibility. And accessibility was really defined that, okay, if we have telehealth or telerehabilitation interventions, could we actually provide this to everyone? So does everyone have access to this? So also the people that are maybe a little bit less digitally inclined, or people of certain backgrounds that might struggle with applications that involve a lot of reading. So this is something we wanted to find out. So for the Canadian situation, it was related to, is there actually anywhere where we want to provide telerehabilitation? Is the infrastructure there? Can people connect to the Wi-Fi? Are there platforms that we can use, and does everybody have access to these platforms? Another question that we had was, is there actually evidence for what we do, and can we already say something about the effectiveness of such interventions, and do medical aids actually cover these type of interventions? And the last question that we had was related to competencies. If we do provide telerehabilitation, do we already as clinicians have the competencies that come from, say, the old-fashioned face-to-face or hands-on treatments? Can we apply this using telerehabilitation, or do we need different competencies? And if so, what are those? Next slide, please. So the aim of the project was to develop an understanding of current practice in both the Canadian and the Dutch context regarding telerehabilitation. And we wanted to find out how this was done among a group of physical therapists, occupational therapists, dietitians, and respiratory therapists. But we also wanted to look at our students, and then especially the students that are in their final years of their entry-level educational programs. Next slide, please. And in this study, we defined telerehabilitation as any interventions or any remote forms of interventions, which could include teleconsultation, telemonitoring, and teletreatment. And then you could put on the next slide, and then I'll hand over to Ed.
Great, thanks, Mel. So what I'm going to do is I'll briefly go over the methods we used to conduct this study. So, there we go. So we used 2 online surveys, and we targeted clinicians and students in Canada and the Netherlands. With the Clinician Survey in Canada, we approached occupational, physical, and respiratory therapists. And in the Netherlands, we approached OT, PT, dietitians, and exercise therapists. The Canadian survey was available in English and French, while the Netherlands survey was in Dutch. We used a variety of avenues to recruit participants, and that included distribution using mailing lists from regulatory colleges, as well as professional organizations, and then advertisement on a variety of social media platforms. For the student version, we targeted only our select universities in Winnipeg and in Amsterdam, and we used student cohorts who were currently either in their final year or had just graduated from their program. The Canadian version was in English and included OT, PT, and RT students. And the Netherlands version was in Dutch or English, and that depended upon which program they were targeting for the students who were enrolled in those programs. We contacted students using the email lists that we had available to us, as well as through a variety of social media platforms. The various surveys were all initiated in late November or early December of 2021. The analysis that we're going to present today is based on the results that we collected on or before January 14th of this year. Both the clinician and the student surveys contained questions that related to respondent descriptors of the people who were responding, Tele-Rehab training that they'd received, their Tele-Rehabilitation delivery through clinical or fieldwork practice, depending on if it was clinician or student, and rating scales about their experience with Telerehabilitation. Both surveys included a standardized measure that related to Telerehab acceptance or uptake. And the clinician version, we also included a standardized measure of Telerehab usability or satisfaction. So now on to the results. We'll begin with the clinician survey. So we had a total of 505 clinician responses, about 89% of whom were from Canada. Now, we did have some attrition over the course of those survey responses. And so we had about 83% of respondents who completed all questions on the survey. We had a roughly equal response from OT and PT clinicians, and that accounted for about 92% of total responses, with respiratory therapy making up another 7%. We only had 6 responses from dietitians in the Netherlands, so we are not going to really report on those results individually. The number's just simply too small. So this figure you see breaks down the time that respondents had been in clinical practice, and you can see that nearly 70% of respondents had been working for at least 10 years. These folks predominantly worked in private practice, followed by hospital and community practice. And a number of respondents indicated that they worked in multiple settings. So those numbers would add up to more than 100%. In terms of client populations, the respondents were typically working with adult or older adult populations, and again, potentially working with more than one age category. Here's a quick overview of the responses from Canada, where most of the responses came. While we were obtained responses from clinicians working in every province and territory, our largest response rates were in BC and Manitoba, followed by Ontario, Saskatchewan, and Nova Scotia. Furthermore, if we look at those provinces, they were largely from single disciplines in each of those cases. And this is probably a result of recruitment through using regulatory bodies. So those regulatory colleges that were able to collaborate with us would target one particular population. Please don't read anything into the red and blue colors. This is not meant to reflect anything political. Only 31% of respondents reported that they had received any kind of Telerehab training, and most of those had got it through online or in some sort of hybrid format. Through continuing education, that was typically supported through work or through their own personal means, and only 5% of respondents identified getting some training as part of their entry to practice program. That was a very small number. Incidentally, all of those folks were from Canada and in either an OT or a PT program. So next, we asked clinicians how much experience they had with delivering Telerehab. And the results were quite evenly spread. We actually have a lovely little bell curve here. Responses were generally comparable between Canada and the Netherlands. If we look at that same distribution, but by discipline, we can see that RT and OT rated their level of experience somewhat higher than physiotherapy. Again, just to be cautious that our number of responses from RT were quite small. So we'll look at those percentages with some caution. We also asked clinicians how confident they felt in delivering Telerehab. And the responses were quite similar to what we saw with the question around experience. And again, this was roughly equivalent between the two countries, perhaps slightly higher in the Netherlands. Again, looking at these same numbers by discipline, OT and RT were again scoring slightly higher than physiotherapy. We asked clinicians how long they had been using Telerehab. And again, the responses from Canada and from the Netherlands were generally similar. What is interesting is about 20% of the Dutch respondents had been using Telerehab prior to COVID, versus about 10% of Canadians who had been doing so. If we look at the other numbers, we can see that about half of respondents were early adopters during COVID. So they were sort of on board between 1 and 2 years ago, which would be the first year of COVID. If we consolidate the data, we do see that OTs and at least 3/4 of PTs were using Telerehab. Well, about 2/3 of respiratory therapists who responded were not using Telerehab. OTs were a little more likely to have been using Telerehab prior to COVID, but those numbers again were relatively small. If we look at folks who were currently using Telerehab, so the folks that said they were using it, about 70% indicated that they would continue to use Telerehab even after COVID was over. Whatever over means, we didn't really define that because we don't really know what that means. And then another 20% stated that maybe they would continue to use it, and only 10% indicated that they would not. So that was interesting. From there, we broke that down and we did look at it by discipline. And here we see that there were some distinctions between disciplines. About 8 out of 10 OTs and RTs responded that they would continue to use Telerehab. Physiotherapists were slightly more equivocal. So about 15% indicated no, they would not, and 35% were in the more ambivalent maybe category. The vast majority of respondents indicated that Telerehab had proved to, I missed a little bit there. When we asked how they were delivering Telerehab to their respondents, folks were using video platforms somewhat more than they were for telephone, but the numbers were not all that different. So they were using both kinds of platforms. Teleconsultation was most frequently used service-wise, followed pretty closely by teletreatment. Telemonitoring of clients was a less common practice, reported by about 1/4 of respondents. These proportions were essentially the same if we looked at Netherlands versus Canada, so they weren't really that different. If we do look by discipline again, though, we do see a little bit of difference between them. Teleconsultation and teletreatment were used most frequently by OT and then followed by PT and RT, while our respiratory therapist colleagues use telemonitoring most often among the 3 disciplines. The vast majority of the participants to the survey indicated that Telerehab had proved unsuitable for some of their clients, and OTs were most frequently responding that this was the case. The potential reasons for unsuitability, though, were quite varied and were distributed pretty evenly between the categories that we offered, which was things like capacity of the client, the complexity of that client's situation or their case, their access to technology, client's inability to use technology or familiarity with it, and the need for in-person or direct physical contact as perceived by the therapist delivering service. With respect to the platforms that people were using, Zoom and MS Teams, along with the telephone, were by far the most frequently reported. The remaining platforms are really quite a mixture of commercial products like FaceTime and WhatsApp, as well as sort of specialty platforms like Jane or PhysiTrack and Doxy. We had respondents And these are folks who were currently delivering Telerehab. We had them rate how effective their Telerehab delivery was, as well as how satisfied they were with their delivery of Telerehab. So I combined these because the responses were almost identical to these two questions. 85% of the respondents rated each attribute to be at least moderate, and over 40% rated it as quite or extremely effective and satisfactory. So those ratings, I think we would interpret as being fairly positive. There again were no substantive differences between countries on this rating scale, nor were there differences really between disciplines on ratings of effectiveness and satisfaction. More than half of respondents indicated that they did not conduct any kind of formal evaluation of the effectiveness of Telerehab delivery. So that's specifically effectiveness of Telerehabilitation beyond their typical clinical outcome measures. Those who did relied primarily on satisfaction or quality of life questionnaires that they had used, and those were a mixture of sort of in-house or available questionnaires. That large-ish other category at the bottom was predominantly situations where they said they would informally ask about what their clients thought about Telerehab, or whether their clients actually kept using Telerehab with them, or some folks identified using sort of clinically based outcome measures that weren't really targeted at Telerehab, just their own clinical outcomes. Now, we also administered a standardized questionnaire to evaluate respondents' perceptions of usability of Telerehab. And the responses were reasonably good. They varied between 4.5 and 5 on the 7-point Likert scale. And there were no significant differences either between countries or between disciplines. So folks really were seeing the usability as quite comparable in both contexts and across the various types of therapists. We also administered the Tam Questionnaire, which is a standardized measure to evaluate the potential for uptake of Telerehabilitation by clinicians. These ratings were slightly higher among the Dutch respondents than the Canadian ones. And we did find a statistically significant difference between disciplines, with OTs being more likely to embrace Telerehab use. We asked our folks what was required to provide Telerehab, and technology issues by far the most commonly identified by respondents. Those included things like access to technology, support for the technology, and confidence in using the technology. These areas highlighted for interest's sake are those that were reported more frequently by the Canadian versus the Dutch respondents to the survey. Then we also asked respondents which issues were barriers to delivering Telerehab. And again, technology issues for both the clients as well as for the clinicians were the most frequently identified, with self-efficacy or confidence in using technology as the third highest response. The need for physical interaction in the delivery of services was the second most frequent, with the remaining issues all being sort of spread out and none of them being reported by more than a quarter of respondents. So those were more of a shotgun response rate among our folks that did the survey. So now we'll move on to the student survey. The response rate was a little bit lower than we had anticipated, actually. We had a total of 66 respondents across both countries. About 74% of those were from Canada. Again, we had some attrition with our respondents as they were completing the survey and had a 71% completion rate where we had a full composite of data for those folks. Our responses or our respondents were again split relatively evenly between OT and PT. And with a smaller response from respiratory therapists, we had about 11% of our respondents were from RT. Students generally did not receive much training in the delivery of Telerehab in their professional program. However, the Dutch students were particularly in that boat and were much less likely to report having received any kind of training as part of their professional program. If we look at those students who did receive training, so that subset, it was generally they were part of their professional program versus in their previous university, probably undergraduate program in most cases, or from other sources. We asked all of our student respondents what other types of resources then that they used to learn about Telerehab. So this was now all respondents, not just those who had as part of their professional training. Canadian students were more likely to obtain this kind of information for themselves via their clinical placements, assistance from peers, and from resources they obtained from the internet or from peer-reviewed literature or from regulatory colleges. Dutch students, on the other hand, relied more heavily on their clinical fieldwork placements, online courses, from peers, and from just sort of general internet searching. Now, we asked students then whether they thought Telerehab should be part of their professional training. And a majority responded yes, but this was a much stronger sentiment among the Canadian students than it was among the Dutch students. When we asked how should this instruction be delivered, most Dutch students felt it should be integrated throughout the curriculum, while Canadian students were a bit more split between having a dedicated module or course on telerehabilitation versus having it integrated across their program. Students reported having only limited experience in delivering Telerehab during their education, with Canadians typically indicating very little, while Dutch students varied between none and some. There was little difference between OT and PT students in this regard, so we didn't display that information. In terms of confidence with delivering Telerehab, responses were a little bit higher and generally comparable between countries as well as between disciplines, but still skewing towards the low end of that scale. With regards to the platforms that students use versus the clinicians, we saw some differences across contexts. So the Canadian rehab students were more likely to have used Zoom or Teams, as well as the specialty platforms like Jane, while our Dutch students more commonly use some of the social media platforms like WhatsApp, FaceTime, and Messenger. Like the clinicians, a majority of students identified that Telerehab had been deemed unsuitable for some of the clients that they had worked with. This was, however, much more prevalent among the Canadian respondents than among the Dutch ones. Students identified that the need for having in-person or physical contact during intervention was the most common reason. So this is much higher than we saw among the clinicians. And then this was followed by those technology issues, particularly client capacity to use or access to technology. We asked students then what they thought in terms of future use, how they might use Telerehab or how they thought Telerehab might apply to their future practice. Canadian students were more likely to see application for things like assessment and monitoring of clients, and were less likely to see application for evaluation of clients than their Dutch counterparts. The students were then asked how satisfied they were with their delivery of Telerehab. And all the students were generally not terribly satisfied, but the OT students appear to have somewhat more favorable experiences than their physiotherapy counterparts. However, students again were more optimistic of their ratings around effectiveness than they were around satisfaction. So they weren't that pleased with it, but they thought it was doing a reasonably good job. And again, the OT students appeared to have a slightly more positive perception of effectiveness than the PT counterparts. Our respiratory responses were so low that it didn't seem fair to include those numbers. Students identified a number of facilitators to delivery of Telerehab, and those were primarily around having good technology setup and sufficient knowledge and confidence in using the technology. Interestingly, Telerehab resources like patient materials, videos, and apps were only selected by about a quarter of the respondents among the students. So they didn't feel that that was a particularly crucial facilitator to delivery. Regarding their perceptions around the barriers then to Telerehab delivery, again, issues with technology itself and client inexperience with using technology were foremost among their perceptions, and that was followed closely by the perceived need for physical touch in order to effectively deliver rehab services. Interestingly, the clinician inexperience with technology and fit with their clinician workload were identified by only a very small number of respondents among the students, despite the students having very low ratings of experience and satisfaction with Telerehab. They didn't feel that that inexperience or fit with workload were the substantial barriers to delivery of Telerehab. And finally, we administered the standardized measure evaluating students' potential uptake around technology or Telerehab technology specifically, which was moderately high, again, between 4.5 and 5 on that 7-point scale. The Dutch students appear to be slightly more likely to embrace Telerehab use than their Canadian counterparts. So that was a pretty high pace run through a lot of data. I'm now going to turn it back over to Mel, who's going to make a little bit of sense out of that and synthesize some of those findings.
Thank you, Ed. What a brilliant presentation, by the way, of the results. And even though the results were not unfamiliar to me, I still realized a few things. So I was frantically writing things that we should really see if we can discuss later with this group. I would like to just highlight a few things that we noticed related to the student results and then finish off with the clinicians' results. And then we will have time for questions and discussion. Yeah, related to the student results, I guess the first thing that is noticeable is that we had very low response and that we talked about that and tried to explain it. And although that might be the most easy explanation, we do think that one of the reasons why we have limited response was related to the fact that students in both countries have had a tough last few years with a lot of restrictions and a lot of online classes, which made them probably less eager to help us out. But also we do acknowledge that that the recruitment could have maybe recruitment strategy could have changed a bit. What also another thing we noticed was that from the PT and OT students, most of them did not receive Telerehab training, but at the same time, we noticed that Telerehab was asked at the clinical placements. So I guess that raises the question: are we sufficiently preparing our students for their clinical tasks at their clinical placements? We'll leave that as with a big question mark for now. Another thing is that that was noticeable that where students were less confident, but at the same time they really believed that what they delivered on Telerehab was effective. So that is an interesting finding, I think, that should be explored further. Then that, yeah, there were less familiarity with available Telerehab platforms, and that students, same as clinicians, found that there were definitely a certain number of patients that were not suitable for Telerehab. And it could very well be because a face-to-face contact was needed, or what was it, hands-on interventions were needed. But at the same time, it could also be that we are actually constantly committing selection bias by deciding for our patients if they are indeed suitable for Telerehab or not. Yes, next slide. Thanks to Moni Fricke, who is here, and I think Rona McWilliam is also here, for sharing this data. I just wanted to add it in because they provided a Telerehab class, and they did the same thing. So they did a little survey in there among their students, and here we can see the difference in scoring between how students perceive how important they feel that Telerehab is in the provision of physical therapy, comparing how they felt in 2020 comparing to 2022, and you see that their perception and of importance has changed quite a bit. And another question that they asked was if they had any personal encounters themselves receiving remote healthcare, and also that had changed quite a bit. So thanks for sharing that, Moni and Rona. And next slide. Going on to the clinician results, we also found some interesting things. Obviously, unfortunately, even though we did fiercely recruited among dietitians with whom we have good collaborations at our faculty in Amsterdam, we did not manage to include that. So focusing mostly on occupational therapists and physical therapists, they were largely experienced before deciding to use Telerehabilitation. They were mostly working in private practice and mostly working with adults. So yeah, that leaves questions for population that we have missed, or respondents that we've missed in this study. It was also interesting to see that if Telerehabilitation training was received related to specific competencies that you might need to provide Telerehabilitation, this was often done outside of the graduate programs or postgraduate programs. Another thing that I wrote down now was that the clinicians, they weren't that satisfied. If I understood what I picked up from the results that Ed just presented, they weren't particularly satisfied with Telerehabilitation, but they did also think it was very effective. So again, these are two things that I think don't match so well. So we should really scratch ourselves behind the ears and think about that. If I could have the next slide. Yes, so I did already talk about the confidence that clinicians felt and that they are keen to continue using it. And it was also interesting that there was some effort to evaluate effectiveness of the Telerehabilitation tools that they used or types of treatments, but this was then, yeah, they didn't get any further than choosing a quality of life tool. So this is something that we should look into. It's nice to find that clinicians are enthusiastic, and I think that also applies to our students, and they want to continue with Telerehabilitation, but they might lack certain competencies, and we cannot really claim at this point that we provide evidence-based Telerehabilitation because we're not using valid tools to evaluate this. So yeah, questions remain about the effectiveness of our treatment, and also which was actually the aim of or one thing that we found really important, this project group, is the telerehabilitation that is offered. Is it an inclusive type of intervention? So do we offer it to all patients that can benefit from it, or are we doing some pre-selection and saying, no, this person has cognitive problems, or that person should not have access, or can probably not benefit from it, etc. So another question that I wanted to raise is, are we, and we can't really answer that based on the study results, I think, but it's an interesting question to explore, is are we able to integrate telerehabilitation in our daily clinical practice, or does it remain one of the tools that we have as clinicians that we could randomly, as we wish, apply in clinical practice? Or will it be a selective tool that we use as an add-on for a particular type of client, like the higher educated client that's already very how do you say that, that already finds it really easy to use this. Last slide, I think, Ed. With this, I would like to acknowledge that Ed and I did not do this by ourselves, far from it. Actually, we had a very inspiring group of colleagues from the University of Manitoba, Kara, Louise, Moni, Paddy, and Pam, I would like to thank specifically. And from the Amsterdam side, I would like to thank Jesse, Margriet, Martin, and Marike very much. And then I think we go on to the questions or discussions. So I'll hand the floor and the mic back to Barb.
Great. Well, I really want to take this opportunity to thank both Ed and Mel for their presentation. I found it very interesting, and I'm sure that a number of you do have some questions. I'm just wondering, is there another slide that we can advertise where to go to give feedback on this? Ed, did you have an address or something that?
Well, we have our email addresses on this slide.
Mm-hmm.
So,
no, sorry, there was
a survey.
You mean the survey?
Yeah.
Yeah, I'll put it in the chat. There's a link. I think
I can put the link in the chat for you.
Okay. All right. So there you go. There's the, if you go to the chat function, then there's a link to the survey that we would be really appreciative if you could fill that out as being a participant on this. I will be able to see people in terms of whether or not you put your hand up, just unmute yourself, and you can use the reaction to put your hand up on the bottom fire. Otherwise, I will also monitor the chat. And so if somebody has a question, you can put it through to the chat as well. So just looking at the people, Amin, you have a question.
Yes, thank you, Barb. Thank you, Ed and Mel. Very good presentation. I think it's very timely topic, and many people around the world are waiting for such a data set, kind of data. So I'm sure you have a nice data set on the table today. I was curious about two results that you have presented in the graphs. And one of them you have three different levels. One for teleconsultations, one for teletreatment, and one for telemonitoring. And you have another one which is just in blue. And for example, sorry, I forgot the number of the slide. And you were presenting kind of issues, and technology issues was like the first one. So I wonder if you can juxtapose the results and see if technology issues are determining the other graph, which is, I'm saying just probably in teleconsultations, technology is way more easy, and in telemonitoring, technology is complex. So I don't know if you have explored the different types of technology, and if you can relate the types and complexity of technology to that graph, and if you are able to, yeah, so probably, yeah, I want to hear from you. So what do you think about if we can juxtapose the two graphs, and what do you think about that in terms of level of complexity of technology versus how it can be used and logistically put in place in today's practice?
Thanks, Amin. That's a very interesting question. Thinking about, I think I know where you're coming from with that. I think one point, we didn't define specifically around telemonitoring what that would entail. So it may be that clinicians would interpret telemonitoring as I'm checking in on my client. So I might send them a text. I might ask them to tell me whether they've been compliant or adherent to whatever intervention we're using, versus a more complex method of monitoring where they might have a sensor or some kind of external data that's coming in. So that was really, we described what telemonitoring was, but we didn't define it in terms of the complexity of the technology that might be involved. So I agree with you that I think if you're getting into use of various sensors or other kinds of monitoring information, that would probably be a tall order for many clinicians to integrate into their tele-rehab practice, given they were thrown into this, many of them without having much experience to begin with. And now you're asking them to combine technologies together. And clearly there, people were identifying even their own self-confidence with using technology as being a major barrier. So if telemonitoring is the most challenging and complex of those three types of interventions, then if you're unfamiliar with it or not confident with it, clearly it would make sense that those would be things that you would be using less frequently. What we don't at hand have as a comparison point is what would be the breakdown of teletreatment, teleconsultation, and telemonitoring, or consultation, treatment, and monitoring without the tele involved. So are they more or less likely to do those things with tele-rehab versus traditional interventions, which would be another interesting question. But yeah, you totally raise an excellent point that would be worth pursuing in more detail, and see how are people interpreting telemonitoring, and is that a more complex, is that a more challenging thing to do? And if it is, how do we support that? Because that's really the next question, right? Like, so what if we know this is a problem? That's really just informs what do we do about this next? And that's sort of the next project or the next step.
Can I ask another follow-up question?
Up to Barb.
Oh yeah, sure.
Okay, thanks so much, Barb. It's really important. So I see another trend in the results, which is really fascinating, which is naturally clinicians are using what they are used to use. I can give an example, whether they are students or therapists, and that's really fascinating. In Amsterdam, they are using, for example, WhatsApp and Messenger. This is why I catch it, what I got from the slides. And in Canada, they're using MS Teams and Zoom and things like that. So if we think that clinicians will naturally use what they are used to use, then I think we cannot blame technology as much, because if we are used to it, we'll use it, right? So again, in your results, in Amsterdam, they're using what they know, what they prefer to use. And same thing in Manitoba or Canada. So do you think that if we get people more used to technology, probably raising awareness about technology or providing formal or informal training, would that be like workshops? Would that be of benefits for people to uptake technology at the two other levels that are the two other complex levels that are the telemonitoring and teletreatment, as you call them?
I think that the uptake that uptake is a little bit more complex, and there's a lot more factors involved to get clinicians or students to take on a fairly new mode of delivering interventions. Even if you use technological systems that you are familiar with, that you use in another way or for another purpose, I think there's a lot more that is needed to be able to provide those interventions, and to feel comfortable with doing that, and to really incorporate it in your clinical practice. So it is an interesting point that you're raising, but I think it's not easily answered.
Yeah, and I think as Moni raised in the chat, there's regulatory issues that might also influence those choices about which platforms. Having said that, the response rate in terms of barriers around those regulatory rules were not selected by many respondents. I have to say we were a bit surprised by that. But Raul, maybe we'll give you a shot here because I'm looking at the clock.
First of all, thank you, Ed and Mel, for this great presentation. I think this is the way that we are bridging oceans, and should be done in future more and more. I got two very small questions. What are you going to do with the results? Is it just a report, or are you going to publish it? And the next question is, well, we have a lot of money left. What would you do next? I said when we have some money left.
Oh, I thought you said, well, we have a lot of money left. Okay. Ed, do you want to go first, or shall I go first? Nice questions.
You go ahead, Mel.
Okay, so what are we going to do with the results? Yeah, I think it's very important to continue talking about it even more, because even now, hearing the results again and hearing the critical questions of the people that are present, that makes me, and I think for the other people in the group, it might be the same. It makes me reflect more and think more, and it raises more questions I wish to explore. So I think we definitely, now we presented the results more or less, yeah, the naked results, but we haven't really discussed them or explored them. What does it mean? So I think there's a lot of opportunity there for continuation, and definitely I understood from Ed that we had more responses to the survey even after analysis was completed. So it would definitely be interesting to, I think we have a nice response, at least from the Canadian side, to see if a publication would be worthwhile, and then if well, there's a lot of money left. Now, when there is a lot of money left, or some money left, yeah, I don't even know if it is about money necessarily. Money helps, but I think it is about having a group of people that are willing to pursue this, and this group has shown that they are inspired and they are willing to meet, even if there are not necessarily enough hours in the day. So yeah, I think we already said to each other we are keen to continue, and a little help from the faculties would be good with that.
And I would say, just in the last 30 seconds, I guess, that I have here, in terms of future directions, I think it's really about, so now we've got the lay of the land, what do we do about it? I think there's at least two avenues. One is we talk to students and clinicians, and clearly clinicians didn't feel like their programs prepared them, and students aren't feeling like we're addressing this well, and I don't think we would disagree with them. So I think taking some action around how do we change our education process is crucially important. And then also, how do we continue to support clinicians, because clinicians are doing it, they want to do it, they want to keep doing it, they've identified some of the barriers, and so how do we leverage creating those supports? And we've already heard back from some other folks in Canada who are doing research or programs to develop resources, which I think would be great collaborations for us to jump on to see what can we do to give people what they need to make this work.
That's great. Well, as we mentioned, you can contact Ed or Mel specifically via email if you like. This session has been recorded, so we will make that available to people who request it. And thank you both again for presenting at the Illuminate series. And yeah, we'll see y'all again. Thank you.
Thanks, Barb.
Thank you. Bye-bye.
Bye.